Actually, I will cover headache in 2 lectures. Today is my first lecture for you. So, um, uh, before discussing headache, first we have to know something about the intercranial structures, which may play a role in the pathogenesis of headache. So, what are the different pain-sensitive structures in the cranium? So, there are some pain-sensitive structures and there are some pain-insensitive structures in the cranium and brain. So, pain-sensitive structures are mainly scalp, dura mater, circle of Willis. In arteries, mainly middle meningeal arteries is pain-sensitive. In cranial nerves 5, 9 and 10, trigeminal nerves, um, glossopharyngeal nerves and vagus nerves are pain-sensitive cranial nerves, and there are some proximal pile arteries. So these are the common pain-sensitive cranial structures. So there are some pain-insensitive cranial structures like brain parenchyma. So actually we think brain parenchyma uh, may have pain-sensitive fibers, but there is no any pain fibers in brain parenchyma. Brain parenchyma is pain-insensitive structures. So brain parenchyma, uh, choroid plexus, ependyma, and distal segments of pile vessels are pain-insensitive structures. So before understanding the headache, you have to know the pain-sensitive structures and pain-insensitive structures. So pain-sensitive structures play a role in headache. So for a revision, pain-sensitive structures are scalp, dura mater, circle of Willis, middle meningeal artery, proximal segments of pile arteries, and cranial nerves 5, 9, and 10. So these are the pain-sensitive cranial structures. Am I audible?
Yes, sir.
So after knowing pain-sensitive structures of the brain, we have to classify different types of headache. So what are the how do you classify headache? Can anyone answer? How do you classify headache? So the headache is broadly classified into primary and secondary headache. Primary and secondary headache. Primary headache mainly includes tension type headache, migraine headache, and trigeminal autonomic cephalgias. So these are the three common types of primary headache. These are the three common types of primary headache. And there are some secondary types of headaches like headache due to infection. So there are different types of secondary headache like headache due to stroke, headache due to any vascular disease in the brain, headache due to head trauma, headache due to brain tumor. So these are all secondary headache. So primary headache is mainly due to benign disease, mainly due to benign illness, and these are the mainly due to benign disease or benign illness, and these are very recurrent. And secondary headache is from known causes of headache like due to systemic infection, like in meningitis, encephalitis, there may be headache due to stroke, due to any vascular lesions, due to brain tumor. So there are lesions in the brain. There may be in secondary headache there may be abnormal neurological examination or there may be abnormal findings in the brain imaging like CT scan or MRI or PET scan or SPECT scan. So in primary headache, the headache is usually benign in nature, and it is usually recurrent, and there is no dangerous complications in primary headache. But in secondary headache, there may be raised intracranial pressure, and it may lead to dangerous headache. And sometimes due to raised ICT, there may be herniation, and patient may die due to coning. These are the broad classification of headache: primary headache and secondary headache. So in primary headache, the most common types are mainly tension headache, migraine headache, and trigeminal autonomic cephalgias. So among these three types of primary headache, tension type headache is most common. We usually confuse in our OPD or in our ward by thinking most of the headache as a migraine headache, as a migraine headache. But most of the headache which usually which we usually encounter in our OPD and what is tension type of headache. So after tension type of headache, migraine headache is common, followed by trigeminal autonomic cephalgias. So in primary headache, first we will discuss about tension type of headache. So what is tension type headache, and what are the special characteristics of tension type headache, and what is the common age group? So the tension type of headache is usually seen in female patients, mainly middle-aged female, 30 to 45 years, and most of the patients, about 1/3 of patients may have associated depression. So the patient is usually a middle-aged female, and there may be signs and symptoms of depression, and there may be issue of workload or stress in the family. So the tension type of headache is most commonly seen in female. However, it may also common in male. And tension type, the typical characteristics of tension type headache is there may be pain-like sensation in the forehead, and it usually occurs bilaterally in both region of the forehead, right and left, and sometimes involving the temporal region. So patient may feel like pain-like sensation or pressure-like sensation, or patient may feel squeezing-like sensation in the forehead and sometimes in the temporal region. So it is a typical character of the tension type of headache. So for your level, you have to know the common age group and sex predilection, that is female, and an association of tension headache with depression and some stress and workload. And you have to know the treatment of tension type of headache. What is the treatment of the tension type of headache? So generally in the treatment of headache, we classify the treatment for acute pain relief and for prophylactic management to prevent the other episodes. So for acute medical treatment for tension headache, we usually use NSAIDs, mainly paracetamol, sometimes naproxen, ibuprofen, like this. So commonly, NSAIDs are the drug of choice for acute pain management in tension type of headache. For chronic management or to reduce the episodes of tension type of headache, we have to avoid the stress. So we have to counsel the patient. Sometimes patient may need psychiatric consultation, so we have to consult psychiatrist for proper mental status examination, and some patients may need tricyclic antidepressants like amitriptyline. So amitriptyline is a drug of choice for prophylaxis of a patient with tension type headache to reduce the recurrent episodes of headache. So for acute medical treatment, we have to give NSAIDs like naproxen, paracetamol, ibuprofen. For chronic management or for prophylactic treatment to reduce the episodes, we will give amitriptyline, tricyclic group of antidepressants. For a level, you have to remember these points regarding the tension type headache. And after tension type of headache, we will discuss about migraine headache. Migraine headache Actually, it is an episodic headache, and in the typical age group for migraine headache is also actually there is no any specific age group for migraine headache, but migraine headache usually starts in the younger age group. Usually starts during school time, during school years. Like migraine headache, first episode, second episode usually starts from 10 to 15 years. Usually during school age, there may be the first episodes of migraine. So, but it may persist for longer age, during adult and sometimes in old age also. So usually occurs in young and adult group of patients. And what are the classification? How do you classify migraine headache? Most of the books has mentioned about the types of migraine headache as common migraine and classical migraine. So what is the difference between common migraine and classical migraine? In common migraine, there is no aura. In classical migraine, there is aura. So 80% of migraine is usually common migraine. About 20% migraine is about 10% is migraine is classical migraine. So in common migraine, there is no aura. There is only headache. But in classical migraine, there is aura. So what do you mean by aura? Aura is a sensory phenomenon that patient perceive, like visual disturbances, like some sensory symptoms like tingling sensation, like abdominal pain. So sometimes there may be hallucinations. Sometimes the patients may hear some voice, may perceive some voice. So that the aura may be visual aura, auditory aura, or sensory aura. So what aura? Typically in most of the patients, since visual aura is more common than auditory aura and sensory aura. So in visual aura, patient usually complain of zigzag lines. Patient may perceive zigzag lines, and sometimes there may be fortification spectra. Sometimes the patient may feel similarity scotomas. So there may be blackish objects. There may be visualization of blackish objects, there may be visualization of dots like signs. There may be there may be basically visual disturbance in visual aura. So visual aura is more common among aura in migraine. So aura is seen in about 20% of cases of migraine, and that migraine is known as classical migraine. But in most of the migraine, aura is not common, like in common migraine. So, and it is common migraine. It is usually comprises of about 80% of cases. So in common migraine, there is no aura, and it usually comprises about 80% of cases. In classical migraine, there is aura, but it only comprises about 20% of cases. Because I have seen most of the students and physicians are confused because they think aura is more. Aura is the peculiar character of migraine, and there should be presence of aura in every cases of migraine. So this is not the answer. It only take 20% of the cases of the migraine you will heard a patient complaining of aura. So after classification of migraine, you have to know the peculiar characteristics of headache of migraine. So what is the peculiar characteristics of headache? We have to remember from you have to remember signs and symptoms of the headache, during the headache and after the headache. So it is easy to remember. So before the headache in uh, in his vision or in his there may be so about 2 to 3 days prior, there may be mood changes and irritation starts. About 2 to 3 days prior to migraine attack. So after 2 to 3 days during the attack of migraine, so before some hours, 2 to 3 hours, there may be aura in patients with classical migraine, and there may not be aura in patients with common migraine. So there may be aura before 2 to 3 hours if there is aura like in classical migraine. So after aura there may be headache. So headache typically involves frontotemporal region, and it is usually unilateral. However, in some patients there may be holocranial involvement of both sides of the cranium. So the most common site is frontotemporal region. Frontotemporal region is the most common site. So you have to remember the site also, which is the common site for the migraine. Frontotemporal region, but sometimes it may be holocranial. That means sometimes it may be bilateral. So basically it is unilateral and mainly occurs in frontotemporal region. So after and the nature of the headache is usually throbbing in nature. The pain is severe. So a patient may usually complain of throbbing pain due to migraine during attack. And after migraine, patient may develop weakness or sometimes tiredness, lethargy. So these two prior to attack, there may be irritation and mood changes, and before the attack, before few hours of attack, there may be aura, and during attack there may be throbbing pain, and the duration usually the duration usually about 4 to 70 hours. So headache usually persists for 4 to 70 hours in a migraine, and this headache is episodic, occurs after a few days or few weeks, or sometimes after a few months. So whenever there is headache, it may persist for 4 to 72 hours. So and after headache also, there may be some lethargy and weakness and some irritation to the patient. So these are the typical clinical features before, during, and after the migraine. So actually, migraine is a diagnosis by exclusion in neurology. In patients, migraine, the neurological examination is normal. So whenever there is neurological examination is normal, and patient may have episodic headache that lasting for more than 6 months, it usually indicates migraine. So disabling episodic headache persisting for more than 6 months in a patient with normal neurological examinations and investigations usually indicates migraine until proven otherwise. So migraine is a diagnosis of exclusion. There should be episodic headache persisting for more than 6 months, and I have already described the typical characteristics of the headache before, during, and after the headache, and neurological examination and investigation should be normal. So some patients, some patients who came in our OPD, and we take the meticulous history regarding the clinical features of migraine, and after, see, if we suspect of migraine, we will send MRI or CT scan to rule out other causes. Because migraine is diagnosis of exclusion. The investigation should be normal. There should not be brain tumor, there should not be neurocystic cirrhosis, there should not be stroke, there should not be any brain lesions explaining that headache. So their imaging and neurological examination should be normal in patients with the diagnosis of migraine headache. So these are the typical clinical features of migraine, and also after discussing these clinical features, most of us think, what is the pathogenesis of migraine? So till now there is no clear-cut evidence for the exact pathogenesis of the migraine, how it occurs and when it occurs and how it occurs. Most of the neurologists and physicians, pathologists, they don't know what is the exact research behind the migraine. Or there are some theories regarding the pathogenesis of migraine, like vascular theory and serotonin theory. In vascular theory, most of the research shows there may be vasoconstriction during the aura, but there should be vasodilatation during migraine. So whenever there is vasodilatation, which results in headache. So this is one theory, vascular theory that usually indicates that vasoconstriction leads to aura and vasodilation leads to headache. And in serotonin theory, the decreased level of serotonin in the patients with migraine, most of the studies had found decreased levels of serotonin. So most of the researchers implicate that there may be role of serotonin, and decreased serotonin may result in a pathogenesis of. So these are all theories. It is not a known theory. And after discussing the types and characteristics and theories of migraine, we have to know the treatment of migraine, how to treat migraine, and the treatment of migraine is very important. When we encounter patients of migraine in our OPD, and most of the doctors we have seen many patients without with many doctors are without doing the recent treatment. They usually give NSAIDs. So there are lots of side effects of NSAIDs. So they usually give NSAIDs for a long period. They we usually encounter patients with migraine. They usually take Flexon, naproxen. Flexon means Flexon. That is a composed of paracetamol and ibuprofen. So some patients are taking naproxen, ibuprofen, aspirin. So we have to give NSAIDs for acute pain management, but we should not give it continuously for a long period because there are lots of side effects of NSAIDs. So what are the different side effects of NSAIDs? NSAIDs usually causes gastric ulcers. Sometimes it precipitates stroke, myocardial infarction, acute kidney injury. Some patients may develop chronic kidney disease, gastric ulcer. So there are lots of side effects of NSAID. Some prolonged NSAID also leads to drug-induced hypertension. So there are lots of side effects. We should judiciously use NSAIDs for the acute pain management, and we should give prophylactic treatment for a long period. So don't give NSAIDs for a long period, or give prophylactic drugs for a long period by addressing the dose and by monitoring the side effects. So NSAIDs are mainly given for short period for acute pain management. So treatment of migraine is also divided into two parts. One is first is management of acute attack or acute pain management or acute management during acute attack, and second is prophylaxis to reduce the episodic headache, to reduce the episodes of migraine. So there are two headings for the treatment of migraine. For medical treatment, what are the different drugs we discuss? First, usually we prefer for mild to moderate cases. So we usually preferred NSAIDs. That is, we usually give NSAIDs or ibuprofen, and sometimes paracetamol as well. So we for mild to moderate cases, we will for acute pain management we give NSAIDs. If the patient does not improve with NSAIDs during acute for acute pain relief, we will give another group of drugs that which are also newer drugs for the migraines. That is triptans. So 5-ST1B1D receptor agonist. 5-ST1B/1D receptor agonist. So 5-ST1B1D receptor agonist are the drugs used in moderate to severe cases, or we can use these triptans for acute pain management whenever there is no improvement with NSAIDs. So what are the different name of triptans? There are the triptans. The common triptans you have to know are sumatriptan. We usually give in the dose of 25 mg and 50 mg. Rizatriptan we usually give in the dose of 5 mg and 5 mg and 10 mg. So in our OPD or in our ward or in our emergency, we nowadays we usually prefer rizatriptan, 5 mg or 10 mg stat, which helps to reduce the acute pain if there is no improvement with NSAIDs. So other triptans are ilitriptan and zolmitriptan. So triptans are usually available in the oral form like sumatriptan, rizatriptan. Some are available in nasal form like zolmitriptan, nasal spray like zolmitriptan and sumatriptan also available in the nasal spray. And sometimes we may need to give injectable triptans like sumatriptan is available in the injection. We will give 6 mg subcutaneously instead. So whenever there is no improvement in the acute pain in migraine after giving NSAIDs or after giving oral rizatriptan or sumatriptan, we will give injection sumatriptan 6 mg subcutaneously. So these are the common drugs for acute attacks of migraine. Besides these NSAIDs and triptans, there are some drugs with moderate effect like ergot alkaloids, ergotamines, dihydroergotamines. So these ergotamines are also used in some patients, ergot derivatives, but we usually prefer NSAIDs and triptans nowadays. So what are the common side effects of triptans? So the triptans basically causes vasoconstriction. In migraine in vascular theory, we knew that there is vasodilatation, which may result in headache. So these triptans 5-ST1B1D receptor agonist causes vasoconstriction and which helps to relieve acute pain in migraine attack. So whenever there is vasospastic disorder or whenever there is narrowing of the arteries like coronary artery disease and cerebrovascular disease, so patients with myocardial infarction and patients with stroke or patients with peripheral vascular disease, triptans are contraindicated. So triptans are absolutely contraindicated in patients with myocardial infarction, stroke and peripheral arterial disease. So because it causes vasoconstriction and it may precipitate myocardial infarction. So triptans we can use judiciously in old age patients and patients with diabetes, hypertension. So patients with risk factors of acute coronary syndrome may develop acute myocardial infarction due to this triptans. So triptans should be judiciously used in patients with vascular disorders, mainly myocardial infarction, stroke and peripheral arterial disease, because it leads to vasoconstriction, which may precipitate stroke and myocardial infarction and peripheral vascular disease. So these are the common drugs for the acute pain management in migraine. Now, after the acute pain management, we will give these prophylactic, different group of drugs for the migraine for prophylaxis to reduce the attack. So I have seen some of the students confused with the use of these prophylactic drugs. So sometimes some patients with acute attack of migraine came in emergency or OPD or ward, and they give this amitriptyline and sodium valproate, propranolol. So there is no role of these drugs by giving a single dose to prevent acute attack. These are for prophylactic to reduce. These are for prophylaxis to reduce the future attacks of migraine. So these prophylactic drugs will take some days for the action. So these drugs takes about 2 to 3 weeks for proper action. So during the acute attack, we have to give This NSAIDs depends on ego derivatives, mainly NSAIDs and triptans. So after relieving and if it relieves with NSAIDs, and I will give about 1 to 2 weeks NSAIDs for that patient and drug for the migraine. And simultaneously, I will give NSAIDs and I will give this prophylactic drugs. And after 1 to 2 weeks, I will stop these NSAIDs and I will continue this prophylactic drugs, and which will reduce the attacks. And I will follow the patient in the OPD regarding the side effects of these prophylactic agents or to adjust the dose of the drugs. So we usually give prophylactic drugs for about 3 to 6 months in the patients with migraine. Some patients may need for more years, but most of the patients usually need these prophylactic drugs for 3 to 6 months continuously. So what are the different prophylactic agents used in migraine? So basically these are the three groups, three lines of drugs for the prophylaxis of migraine: first line, second line, and third line. So first line means we usually prefer this first line as a first agent in our OPD or emergency or ward. So first line agents we usually prefer propanolol, amitriptyline, or topiramate. These are the three common drugs for the first line agents for the prophylaxis of migraine. In the second line, venlafaxine, sodium valproate, and diltiazem, they may have a role in the to prevent the recurrent attacks of migraine. These are the second line of drugs: venlafaxine, diltiazem, and divalproate or sodium valproate. Mainly in headache, we usually give divalproate sodium. For seizure, we will give sodium valproate and valproic acid. For the prophylaxis of migraine, we prefer divalproate sodium. And in third line, pyzotropine and flunarizine. So flunarizine, pyzotropine, these are the third line group of drugs for the prophylaxis of migraine. So among these first line, second line, and third line. In first line, propanolol, topiramate, and amitriptyline. Second line, venlafaxine, diltiazem, and divalproate sodium. In third line, flunarizine and pyzotropine. So we basically choose the drugs from first line. If this first line prophylactic group of drugs are contraindicated, or sometimes it is not available, or we should choose second line or third. We should choose drugs from second line or third line. So basically in migraine patients we will give drugs for acute management, and we should give drugs for prophylactic treatment to reduce further episodes. So these are the main treatments for the management of migraine. And another important point is nowadays recently newer drugs is available for the migraine, like monoclonal antibodies. Actually, like monoclonal antibodies. So monoclonal antibodies are biological agents. You have heard about monoclonal antibodies recently. Tocilizumab is a monoclonal antibody used in COVID-19, severe COVID-19. So monoclonal antibodies is also available nowadays for to prevent the attacks of migraine. That is calcium gene-related polypeptide antagonist. Calcium gene-related polypeptide antagonist, that is Erenumab, E-R-E-N-U-M-A-B. Erenumab is a monoclonal antibody for the treatment of migraine. So it is basically calcium gene-related peptide antagonist. So Because I have told you vascular theory about vasodilatation and vasoconstriction causing aura and headache, about serotonin theory. There are some, recently there is one concept of the role of calcitonin gene related peptide. Calcitonin gene related peptide polypeptide. So CGNRP. So there is a role of this CGNRP and this newer drugs, irinumab, monoclonal antibody, blocks these calcitonin gene related peptides and it decreases the episodes of migraine headache. So this is the recent drug. For your level, you have to know the you have to know in the treatment part. You have to know about NSAIDs, triptans. You got derivatives and prophylactic first line, second line, third line. You don't need to remember these monoclonal antibodies, but this is a newer one for the many recently available in the developed countries. But it is not this recent drugs for the migraine. It is not available in our country. In our country, we usually prefer NSAIDs, mainly naproxen, and prophylactic agents like amitriptyline, topiramate, and propranolol. So these are the basic things about the tension headache and migraine headache. We'll discuss about trigeminal autonomic cephalgia, which is another type of primary headache in next class. Today we have discussed about we have discussed basic thing, painful cranial structures. I mean pain sensitive cranial structures. Second, classification of headache, primary and secondary headache. Third, among primary headache, the three are the common. Among three, tension headache is more common, followed by migraine headache and trigeminal autonomic cephalgia. And we have discussed detail about tension headache and migraine headache. In next class, we will discuss about trigeminal autonomic cephalgia and some characteristics of secondary headache. So this much for today. Any questions?